under Russ's leadership, Chime has had a more significant role in Washington, and I really appreciate that. I'm wondering if the task force has been able to help move things forward in Washington with regard to policy.
We were lucky enough, we, the Opioid Task Force, for Chime to allow us to tap into some of their existing strength and capabilities, one of which was a Washington-based lobbying team. And part of their efforts, well, all of their efforts, was to promote Chime's agenda in Washington. We were then lucky enough to be allowed for them to promote with some of their energy Chime's opioid task force specific agenda. And so they were very instrumental in the scramble that occurred, the funding scramble that occurred in 17 and 18, that resulted in a pretty massive, in the billions of dollars infusion into, it was Washington's way of trying to make a difference, whether it was prevention or treatment and or education and or access to technology. There was literally billions of dollars that were funded, and Chime's lobbying team, in part fueled by the Opioid Task Force representatives, that was a gigantic victory. More work continues.
I can give a little color on a couple of policy issues that I think were particularly important, and maybe Scott can do a little bit of an embellishment too. But I think that a couple of technologies specifically have great relevance to the IT. One is EPCS, or electronic prescribing of controlled substances. And I think this is a good topic to consider when you really, as clinicians, we need to own up to the fact that prescription drugs were a big part of this problem. And we all know a lot of the history behind pharma and clinicians, and even things like the culture that we grew up in with the Joint Commission and others treating pain as the fifth vital sign. And if you're not treating pain down to zero, you're not doing anyone any favors. And actually giving too many of these prescription medications to patients that ended up creating people that were addicted, that fed into this cycle. There's a long history there, and I don't want to go too much into that, but from an IT perspective, shedding light on all of this process and creating an electronic prescribing system that is transparent and accountable, efficient, audible, but again, needs to be a good technology, because you can't put expensive, onerous technology that blocks clinicians from doing their job. You need a good technology that actually does all those things from a regulatory and auditing standpoint and prevents misbehavior by a certain minority of clinicians. But something like EPCS and influencing that in the right way with those advocates on the Hill, but even more importantly at the state level, to say, look, we need good technology. It can't be too expensive. It can't be too onerous, but it needs to be there. And we need to modernize the way that we prescribe. Another case would be PDMPs, or the prescription drug monitoring programs, where we actually can have visibility as frontline clinicians and others to who's actually been getting prescription medications and where have they gotten them. And lack of interoperability there has been a blocker in the past. We're getting over some of those humps, but the fight is not over there as far as standardizing and working on those systems. But that's right to the heart of what IT can do, is to make these systems easier and readily available to the practicing clinicians. And that really takes cooperation between the providers, the legislative bodies, the monitoring and auditing bodies, and the vendors involved, like EHRs and other vendors, IAM management, and EPCS. So I'll turn it back to Scott and Matt and others for comment, but I just want to highlight a couple areas where advocacy lined up with the practicality of the frontline tools.